Hello, everyone, and welcome to this physician-led webinar on precision medicine for the treatment of fluid overload in patients with acute heart failure. CHF Solutions is honored to host Dr. John Jefferies, who will discuss how to use ultrafiltration or how the use of ultrafiltration can provide precise removal of isotonic fluid in heart failure patients, which can help improve outcomes and reduce hospitalizations. All participants will be in listen-only mode. We encourage attendees to ask questions as they have them via the Q&A panel at the bottom of your screen. Participants on this call are advised that the audio of this conference call is being broadcast live over the internet and is also being recorded for playback purposes. A recorded version of this webinar will be available at www.chf-solutions.com. Next slide, please. These are our forward-looking statements and additional information about AQUADEX SMARTFLOW system, both of which are available on our website. Next slide, please. And now I would like to introduce Dr. John Jefferies. Dr. Jefferies is the J. M. Sullivan Endowed Chair in Cardiovascular Medicine and Chief of Cardiology at the University of Tennessee Health Sciences Center. He also serves as the director of the University of Tennessee Methodist Cardiovascular Institute and the Methodist Cardiovascular Service Line. Dr. Jefferies is also a professor of pediatric cardiology and a research member of St. Jude's Children's Research Hospital. Dr. Jefferies graduated from the University of Tennessee College of Medicine and did his residency and fellowship at the University of Kentucky in Lexington and Baylor College of Medicine in Houston, Texas. Prior to joining UT Methodist, he was a professor at the University of Cincinnati and Cincinnati Children's Hospital. Dr. Jefferies has published nearly 250 articles and abstracts on a variety of topics and has authored chapters in over 15 textbooks. I would now like to turn the webinar over to Dr. Jefferies.
Thank you, and thank you everyone for the opportunity to speak with you today. I look forward to some thoughtful questions at the end, and hopefully some of the information I'll convey to you will be provocative and something that will help you to think differently about how you manage heart failure. These are my disclosures. So we have some training objectives. We would, by the end of this training, we would like for you to be able to understand the causes and impact of hypervolemia or fluid overload. We'd like for you to understand the limitations of current therapies, including things like diuretics. Describe how AQUADEX SMARTFLOW therapy can achieve treatment goals. Understand patient selection, venous access, anticoagulation, and ultrafiltration blood flow rate considerations. And then perform AQUADEX SMARTFLOW system setup and troubleshooting. So as you can appreciate, there are multiple causes of hypervolemia, some more common than others. So in our trauma center, for example, we may see severe burns. In our other units, oftentimes, especially in the current era, we may see things like sepsis, but obviously things that have been prevalent over many years and continue to be a driver for morbidity and mortality in the United States and across the globe are congestive heart failure, obviously a significant cause of hospital cost, admissions and readmissions. Coronary bypass grafting or cardiac surgery, anytime that cardiopulmonary bypass is required, is something that could be driving hypervolemia. The nephrotic syndrome, where you're losing a lot of protein in your urine and changing your oncotic dynamics. Kidney damage, obviously, could be in the form of acute or chronic or both, that can lead to kidney dysfunction and retention of water and or sodium. Liver damage, obviously a concern when we see people with impaired synthetic function. So if they can't make things such as albumin, they're going to third space fluid simply because of oncotics again. And then myocardial infarction, which continues to be a problem, and it's even more of a problem recently in the setting of COVID, simply because of people being very concerned about going to the hospital or otherwise in the setting of chest pain, and perhaps actually having a myocardial infarction and completing their myocardial infarction, which obviously subsequently leads to myocardial dysfunction and then the potential for heart failure. So signs and symptoms of fluid overload, and I'm sure everyone is familiar with some, if not all of these. Jugular venous distension is obviously an important thing, and I do recognize that in the current era, I don't think people are as reliant on physical examination skills as in the past, but this is something that can be seen. Obviously, you can see peripheral or sacral edema, and it can be significant. And I do think a lot of people forget to look for sacral edema, and especially those patients that are non-ambulatory, have limited ambulation. The sacral area is a very common space to have evidence of edema. Pulmonary rouse is something obviously you can auscultate, and you can see evidence of that equivalent in some ways on a chest x-ray by seeing curly B lines. You can see pulmonary edema or pleural effusions on a chest radiograph, but sometimes you have to have a significant amount of fluid before you can actually appreciate that on a radiograph. You can have paroxysmal nocturnal dyspnea or orthopnea, and orthopnea obviously is something that we ask about all the time, and it's something that we can see both in our heart failure reduced ejection or HFrEF patients and our HFpEF, heart failure preserved ejection fraction. A respiratory rate greater than 20 is typically concerning and something that you could investigate that may be consistent with being fluid overloaded. And then obviously, if you have some sort of invasive monitoring, you can assess an end diastolic pressure or a surrogate, a wedge pressure in the absence of any significant mitral disease or pulmonary venous disease. And if those pressures are greater than 20, that also might be something that's going on that's driving some of that fluid overload. Remember, clinically, whether it's children or adults, most common cause of right-sided heart failure, which is all the edema we're talking about, is left-sided heart failure. So something to keep in mind. So we know, and you can see in the gray box, that 90% of heart failure hospitalizations due to signs and symptoms of fluid overload. So that's a lot, and that tells you that's a target. But if you think about how we manage this, we've done the same thing for many years, for decades, and that's typically bringing people in, diuresing them aggressively, and then potentially sending them home. And oftentimes, in my opinion, those patients haven't really been adequately diuresed or unloaded. I don't think they're actually in a euvolemic state. And so we'll talk a little bit more about that in a few minutes. But we do know in the US, leading cause of hospitalizations over the age of 65 is heart failure. And we know there are over 1 million heart failure hospitalizations annually in the US. And as we've just stated, hypervolemia is the driving cause for the majority of those. And the average length of stay for heart failure in the US is about 5 days. And the number of heart failure hospitalizations are actually a strong predictor of mortality. And so I tell people this is an important nuance to understand, is that every time you get admitted with heart failure, it's sort of a stair step that your mortality risk goes up, 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 up. And so the idea that, well, if I didn't diurese them adequately, discharge them, well, they'll come back if I didn't, get everything completely taken care of. If they come back within a week, they're a frequent flyer and we'll just do it again. You've actually increased that patient's chance of mortality. So the idea of just getting them out of the hospital quickly is the wrong one for the most part. It really has to be in a reasonable time when they are adequately compensated. And so that's a different discussion than getting them out quickly. And so I would urge everyone to think about that, simply because all of those bounce backs are actually increasing the chance that patient's going to die. We know about a quarter of heart failure patients will be readmitted within 30 days, and about half of them will be readmitted within 6 months. So if you think about what I just said, we're talking about 500,000 people basically potentially being readmitted within 6 months. And we know that that drives your mortality. That is a significant problem. So that's something that we really need to address. Since 2012, Medicare has levied penalties for hospitals with 30-day readmission rates above that which is expected. And that is an important number that many hospital systems know, but I don't think we actually think about it on a day-to-day basis in the trenches and how much money that actually costs a healthcare system. And where could you be using those resources in a different way to potentially curb these sort of alarming readmission rates? And so that's something I think that we can talk a little bit about. So hospitals can lose up to almost 3% of Medicare reimbursement for all admissions. So that's a pretty significant hit. And I think most people recognize that, but you know, when you think about a healthcare system the size of ours, or many of the folks that are on this call that have large systems, that's a tremendous amount of income that's potentially being lost that I would argue, at least in some cases, is avoidable. So we do know across the globe in the United States that diuretics are sort of the mainstay of treatment of fluid overload. And diuretics definitely have their place. They've been there for a long time, and it is something that we like to use in our outpatient or ambulatory space, right, to keep people out of emergency rooms, to keep people out of the hospital. But they do have their own sort of unintended effects. So the longer a patient's on diuretics, the less effective they become. So this concept of tachyphylaxis, which exists very much with loop diuretics, which is what we would commonly use in this scenario, at least for that acute intervention. And so what that also can lead to is an increased risk of worsening renal failure and accelerated kidney function decline. I find it interesting. I see a lot of patients that will come into clinic and we're managing them for heart failure, but they maybe have been managed by other providers and they're on chronic Lasix, maybe once a day, maybe twice a day, and have been for years and years and years. And my question to them is, do you need it? And they're like, I don't even think it works anymore. The point is we try and get those patients off of that therapy because that's my rescue. That's my opportunity to get fluid overload in the ambulatory space. It's to mitigate that. So, and it is toxic to the kidneys over time. So all those things, I think people think about loop diuretics like Lasix as benign and just something that's there. One, they're absolutely not benign. And two, they're only treating the symptoms of the disease. They do not treat the disease. If anything, they make the disease potentially worse over time. So that is not something that you want to pursue. And so we try and wean people off as much as possible. Are there roles for other diuretics chronically, such as MRAs and other things? Absolutely. But for this particular scenario, we ask people to think about what they're doing, at least in a longitudinal way. We do know there's a high incidence of poor diuretic response among patients. So maybe 40% have a poor diuretic response and maybe up to 70% have a suboptimal response. And that's important because once again, you have that patient in the hospital and the clock is ticking. We're trying to make it in that magical 5 days, but we also know that everyone's not going to be the same. Everyone's not going to respond exactly the same to that bolus dose or that infusion of a diuretic. So that's something that you have to keep in mind. And I would argue in most practices, the natural response is just to give more. Sometimes that's okay, but not all the time. And are there other opportunities? And there are, and we'll talk about that. And obviously, you know, things like electrolyte derangements and the effects of that, symptomatic hypotension from aggressive diuresis, especially in our cardiac patients, can be life-threatening. Hypokalemia is not a good thing in someone who has myocardial dysfunction. So those are things that you have to think about. And then obviously this high risk of rehospitalization, we're talking about a quarter in 30 days and half in 6 months. That is a lot of patients, and it's just something we have to understand and see if we can head that off of the pass, simply because of what I told you. Every time they get admitted, their likelihood of mortality increases. So this was, these data are from the ADHERE registry. I don't know how many folks were around when ADHERE was up and running. I was, and we were a part of all of that. Tremendous registry though, because it had such a large number of heart failure patients. And as you can see, out of greater than 50,000 patients, half of hospitalized heart failure patients are discharged with residual fluid excess after receiving diuretics. So this comes back to my point. Most patients leave the hospital and they're not adequately compensated. So I think in most practices, people give diuretics, maybe don't always know what the dry weight is. So they're going to diurese until they see the creatinine starting to bump. And then they're going to stop or they're going to slow down, okay? Because they think, well, we've done about all we can do. Well, not true, because a fair amount of that fluid is probably extravascular. And so by definition is not going to be mobilized by diuretics straight away. That fluid has to be mobilized. And so I think that that's an important concept, that just because their BUN creatinine started going over 20 doesn't mean you've adequately diuresed the patient. So that's something to keep in mind when you're managing patients. And there are other ways and other strategies to assess if fluid excess still exists. And those are things that, you know, we could obviously talk about in a different session, but there are more objective ways to assess for residual volume overload. And I would encourage people to think about that, because if you don't have that patient at a euvolemic state, the likelihood of bounce back is much higher. And we always target this idea of a dry weight, but for people that have heart failure for so many years, what is their dry weight? Do you really know for sure? I'm not sure we always know. So maybe you need more objective data. So about half of patients discharged with weight loss of less than 5 pounds from these admission data. And that's probably pretty good evidence that you needed to diurese more. And some of these patients, unfortunately, actually gained weight before they left the hospital, which is a little bit concerning unless that was a very chronic stay and there was nutritional problems and whatnot. And then I'm sure everyone is aware of the DOSE trial, looking at different diuretic strategies. And basically, a little less than half acutely decompensated patients reached the composite endpoint of death, rehospitalization, or ER visit at 60 days. So 42%, that's quite a bit. That's also alarming and quite troubling. So remember, we're talking about bolus dosing versus a continuous infusion. Still a long way to go. And these are the same therapies we were doing 20 years ago. So it's something that we need to rethink. So what are the other options? Well, there are other options. And one option, obviously, is this idea of ultrafiltration. And obviously, you've heard a bit about it and you're interested in learning more because you're listening to me, and we appreciate that. So a few things that you might want to take away. One is that there's no major shifts in electrolytes. So meaning you're not going to have the potassium, the magnesium derangements that you see with diuretic use. It's shown to reduce neurohormonal stimulation. So if you look at diuretic data, loop diuretic data such as Lasix, they increase the RAS system activation. Well, think about that. That's everything that we're trying to combat with our medications. We're actually stimulating or accelerating with the use of diuretics. So obviously, anything we can do to squelch the SNS, anything we can do to squelch the RAS system activation is favorable for the patients. You can stabilize or improve cardiac hemodynamics, and it kind of makes sense, I think, in some ways, because you have a more controlled way that you're taking off volume. Everyone knows that, you know, we can shift patients from stable to unstable by giving them a liter of fluid as a bolus, for example. Same curves going the other direction. If you take off fluid quickly, you can cause some problems. And once again, when you give that bolus dose of diuretic, you have no idea how much urine output the patient's going to have. And that could induce hemodynamic instability. And if you think of that large group of patients that we manage, HFpEF, that are very much preload dependent, that's not a good thing. You want to make sure that you have control over the volume status of your patient. And I would argue you just can't do that reliably with diuretics. You can restore some diuretic effectiveness. So I think it's this idea of kind of breaking this cycle of allowing the kidneys to, in some ways, sort of rest a little bit and sort of reset the baseline. And I do think that that's something that we see with ultrafiltration. About half of these patients that we see a reduction in the risk of rehospitalization. We'll think back to those numbers we talked about with the rehospitalizations. That's a huge number. So that's a big savings for a hospital, but more importantly, that's a big impact on patients' mortality. And I think obviously that's our primary focus here. And then early initiation seems to help establish euvolemia a little bit quicker. And there are some data to suggest that it decreases hospital length of stay. This isn't a huge leap. It's kind of common sense. If you start this on the front end and you know how much fluid you want to take off, which you can assess and you can dial it in and predict that, as opposed to putting someone in the hospital and treating with diuretics for 3 to 4 or 5 days, they're diuretic resistant, they still aren't mobilizing fluid, their creatinine is bumping, all those sorts of things. What can you do to avoid that? Well, it may be that you don't really employ that aggressive diuretic strategy on the front end. Maybe you actually think about doing ultrafiltration on the front end, which is something that we've tried to do. And there's some ideas about that that we'll talk about is how can we establish on the front end which patient may be a good candidate for ultrafiltration? And we can talk a little bit about that. So we do know that this reduces the duration of assisted ventilation post-op. Kind of makes sense again. If you've seen people coming out of after cardiopulmonary bypass, you'll see them 6, 8, 10 liters ahead. How are you going to mobilize all of that? Well, a lot of times you'll start them on scheduled Lasix. Well, that's a lot of fluid to mobilize with Lasix. Once again, in a patient who probably is diffusely inflamed, so they have leaky capillaries, everything else. So this is a strategy to help manage that fluid in a very controlled way. If you combine conventional modified ultrafiltration, it is very safe and it's very effective in adult cardiac surgery patients. And there are centers around the country that are doing this and are seeing just spectacular results. And that translates into less time on a ventilator. So that's less time for a pneumonia, less time in the ICU, which inherently reduces mortality. And then a reduced length of stay overall, which I think is fantastic. And remember, post cardiopulmonary bypass, you're saving the kidneys. AKI is very common, something we want to avoid. So this is an opportunity to help do that. It can improve cardiac performance, which I think is an important thing, obviously, to help mobilize fluid and to perfuse those end organs. And then it may reduce the need for blood transfusions. And this is something that's kind of exciting. That there are some other technologies out there helping people to understand really what the difference is between a dilutional anemia and a true anemia. And so I think ultrafiltration, taking away that free water, can perhaps inform people about when they really need transfusions and when they really don't. So these are the current indications for the SMARTFLOW system. And so it's a continuous ultrafiltration therapy up to 8 hours, or it can go longer. And this is the typical scenario for us, is that we do run it longer for those patients that are hospitalized. It can be used in adult patients, which we've done, and it can also be used very well in pediatric patients, which I've done. But we typically do use 20 kilograms or more from the volume overload in those patients that are unresponsive to conventional medical management. And obviously, the therapy needs to be administered by a healthcare provider, either in the outpatient or the inpatient setting in the United States. The majority of these therapies you're going to see are going to be in the inpatient setting under a physician prescription. And obviously, there are a myriad of physicians and disciplines that manage ultrafiltration. But both of these groups need to have received training in extracorporeal therapies. So these are some of the clinical data that exist out there for the use of ultrafiltration. And you can see the history behind this is pretty old. I mean, we're talking 2003, so 17 years ago. And obviously the numbers aren't as robust as you might see in the latest Entresto trial or whatever the case may be, but very much on the initial part, proof of concept that it was safe and it was efficacious. And then how can you assess people, use things on the front end, things like early ultrafiltration versus diuretics such as rapid HF. Unload, I'm sure everyone has heard a lot about. That was a very important study and had some very impressive findings. CRRT-HF was the follow-up study to Unload and was obviously multi-center, was published in New England Journal. And the findings there weren't really as positive as I think was anticipated based on Unload data. And I think there are some inherent limitations to the study design for CRRT that really kind of bias the potential outcomes, mostly because the rate at which ultrafiltration was ordered was a set rate at about 200 cc's per hour. And everyone knows every patient is a little bit different. And the idea that you can just go in, turn it on, and come back later and see how it looks is probably not really the way we would typically manage patients. So I think that that really had a lot to do with some of the equivocal results that you see in CRRT. And then AVOID was an important study that was a prospective study that was stopped early. But there were some findings. There were fewer patients rehospitalized at 30 days and fewer days in the hospital due to heart failure readmissions, both of which obviously are important based on what we've been talking about. So these are just some pictures of the components of the system. So you have a console, you have your venous catheter, obviously could be central or potentially peripheral. And then your blood circuit set, which is, critical to this because obviously this is an extra corporeal or outside the body therapy. And so oftentimes people may ask, well, if you're going to do all this extracorporeal stuff, why not just do renal replacement therapy? And there are a few reasons. One, obviously, is that it's more expensive and those sorts of things when it comes to CRRT. But there are a few other things that I think are important. And one is the amount of flow that you can achieve. And you can run the AQUADEX system on a much lower flow than you can a CRRT circuit, which I think is very important. But also the amount of blood that's outside of the body during therapy, certain about 35 mLs max for AQUADEX, as opposed to maybe up to 300 cc's with CRRT. And then as we've talked about, the venous access does offer you a little bit more flexibility because you potentially could do this peripherally, or obviously you could do it centrally. You're typically talking about a dialysis catheter for CRRT, which is obviously going to be central and something that oftentimes is a little more involved when it comes to placement. So all those things I think are an important clinical consideration. And so this is just a nice video of the system and how things work. So you have this extracorporeal pump, as we talked about. And so you're going to take fluid out. And as we said, it's about 35 mLs. And we're going to take blood out and we're going to run it through the system. And I think the key about this, I think one of the things that's so fascinating for me and then for the patients is the fact that you can actually watch the fluid collecting in this bag, and people like to do this. And this is back to the idea of being isotonic. So the idea that we're leaving, those essential electrolytes that may be promoting things like dysrhythmia, all those things are mitigated in a very neutral way. So you're not inducing those sorts of states with your patients. But I still think one of the fascinating things is just for patients and for providers to be able to look at the fluid collection. And our patients are just enamored by it. It's just something that they sort of fixate on because they know that means that's one step closer to potentially getting out of the hospital. So when we talk about venous access considerations, it's usually a 14 or 16 gauge lumen. And if you wanted to do a central venous catheter, you could do a dual lumen with 14 or 16 gauge lumens, or you could do a quad, which has at least one 14 gauge and one 16 gauge. And there is this opportunity for the extended length catheter, which is this peripheral access, which I think is hugely exciting. If I, as a patient, have had the opportunity to have a peripheral line as opposed to an IJ, I'm pretty sure I know which one I would pick, as long as I knew that the efficacy and durability of each is relatively equivalent. So we don't typically recommend catheters with a lumen size that's smaller than a 16 gauge because of the concerns of flow, and this is just a physics discussion. PICC lines typically don't work quite as well. A lot of it, I think, is because of the collapsibility of those particular lines. That's just not what they were really designed to do. And then obviously peripheral IVs, no matter what the board is going to be, they aren't going to provide the amount of flow that we're talking about here to sufficiently do the therapy and avoid any sort of coagulation problems. So we talk about anticoagulation considerations. And anticoagulation is really there to help you extend the life of that filter, so hopefully for 3 days. And heparin is what we typically use, but obviously in the setting of HIT, you may think about something like argatroban, and that's something that, you know, clinically your hematologist could help you with if you so needed. And usually we try and start the anticoagulation about a half hour prior to starting ultrafiltration. And usually that's pretty easily accomplished because this isn't something you're typically emergently going on to, so you can plan ahead. And we do try and run our therapeutic range of PTT about 80 to 100. If you're using ACTs, 180 to 220, and if you want to use an active anti-factor TENNE, 0.4 to 0.7. Our experience is typically in the PTTs, and I think most institutions would be very familiar with that. Anyone who's using heparin therapies, which would be most all hospitals in the United States. And then always follow the appropriate and applicable local institutional and or hospital policies, procedures, and requirements, meaning about how your dilutions of heparin, how you're going to hang your heparin, how you're going to check your levels, all those sorts of things, I think oftentimes are dictated by local process practices, which probably are relatively similar at most places. There are some folks, obviously, where traditional approaches to anticoagulation may not be appropriate, and so you can do non-weight-based heparin dosing, as you can see there, with a drip 300 to 600 units per hour. Something that, you know, probably wouldn't commonly be employed, but it is something that you can do. You can use ECMO heparin protocols, and obviously those are a little bit tighter ranges simply because of the concerns of bleeding and otherwise problems that go along with ECMO. But obviously that means a little bit tighter surveillance, a little quicker reactivity. So it's something that should be taken with the understanding your infrastructure needs to be able there to be able to do with it. And then heparized saline, if you needed to prime or reprime the circuit, you can obviously do that. And you can consider bolusing of heparin prior to the initiation of therapy. You can do a non-weight-based option, which I think most people would be familiar with, or you can do traditional weight-based loading. We typically have not seen the need for that in our practice, but it doesn't mean that there aren't going to be instances where that would not be appropriate. There are alternative administration sites for heparin. So you can do it from the withdraw from the access port. And then the cardiothoracic surgery is usually for low doses, which I think makes sense because those patients are going to come out and they've probably been anticoagulated during their procedure. And then we typically don't use citrate. Obviously, this is something that you might see more in the CRRT realm, but something we don't typically do in ultrafiltration. So these are just some of the ways you might think about setting the rate when you come in to program the machine. And remember, these are not set numbers. I think that that is a critical component to the clinical use of this therapy. It's not like caress. You don't just dial in a number and don't change it. Look at the patient, react to what's going on. So the fluid is withdrawn from the intravascular compartment and it's refilled with the overhydrated interstitium. So that's kind of the important part that we were talking about. For these fluids to be mobilized, whether it's a diuretic or whether it's ultrafiltration, it has to be intravascular, period. And so that is something that's important about this technology is not only are you taking fluid off, you're bringing some of that extra vascular fluid, that third space fluid, back into the intravascular compartment where it can once again be removed from the body. So I think this comes back to this euvolemia idea. If you're only treating based on your serum creatinine, well, you may have gotten rid of the intravascular fluid, but that doesn't mean you got rid of the extravascular fluid. And so you can look at this thing called this plasma refill rate. And I think that this is, once again, I just think this is a very important concept, is that you're thinking about the entirety of the patient when it comes to volume overload. And so your rate is going to be the rate of fluid volume removal from the intravascular space, but the plasma refill rate is the rate of fluid volume transport from that interstitial space, extravascular, to the intravascular space. And that's a very important thing because it's going to help you to know when your patient is really back to that euvolemic side. The plasma refill rate generally declines during ultrafiltration with a reduction of extracellular fluid in interstitial space, which is obviously a good thing. And then to prevent hypovolemia, the rate should not exceed that plasma refill rate, which sort of makes sense. You don't want to take off more than what you can fill in, because then once again, you may be, from an intravascular perspective, may be hypovolemic and could cause problems to end organs. So what are some other things that you might consider doing to help inform you about the utility and maybe the duration of your therapy? And these are a couple of things that people are starting to really look at. And I think that this is great because these things are being leveraged in this technology, and it's something we use clinically. So you can look at the hematocrit, and it does give you an idea about blood volume changes in real time. And I think it can give you some information about when that patient maybe is almost ready to at least dial down, if not dial off, of ultrafiltration. And interestingly, in these consoles, you can actually set that number automatically based on a predefined hematocrit. Or you can just monitor the hematocrit. So you can either set the machine where it would turn itself off, or you can have that monitoring and it will inform the provider, which I think is very thoughtful and very forward thinking. And you can set it to 15-minute averaging, which I think is good, especially our patients that are starting to move around the hospital, which fortunately the majority of them do, or maybe every minute or so for those patients that are non-ambulating. The values are graphed and visible on the console, which is fantastic, along with your SvO2. So SvO2, I'm sure everyone is familiar with, and is thought to be an alternative to cardiac output, which is a little bit of debate here and there about those sorts of things, but it's an important clinical data point, especially for trends. And so SvO2 is the percentage of oxygen bound to hemoglobin in blood returning to the right side of the heart, right? So, and usually going to be you would have around 75% or so would be kind of what you would typically see. And it reflects the amount of oxygen that's left over, quote unquote, after the tissues have removed what they need, which is that one component, that 25%, 1/4. So both in surgical and septic patients, pulmonary edema may prolong the duration of mechanical ventilation, which we all know is not a good thing because of the length of ICU stay and because of the risk of ventilator-associated pneumonia. And so hematocrit and SvO2 remaining within the target range is a pretty good way to ensure ultrafiltration does not induce significant changes in blood volume and cardiac output, meaning on the low side, that they're not pushing you into a low cardiac output state, which obviously is not something we would want to do in the setting of heart failure. So fluid removal considerations in heart failure patients. Typically, the initial rates are between 20 and 40 mLs per minute. And like I said, that is adjustable. And the range is going to be up to half a liter per hour, which is pretty remarkable. And as we talked about, we don't want that rate to exceed your plasma refill rate, I think, for obvious reasons. And then you can gauge the blood pressures will inform your ultrafiltration rates. So obviously, if the patient's a little on the soft side from a blood pressure, even hypotensive, you probably don't want to be as aggressive. So you might think about 150 cc's per hour. A little bit better blood pressure, a little bit more aggressive, and over 120 systolic, maybe you're looking 1/4 liter an hour. And so that's something to think about. You probably want to decrease your rate, and 50 cc's is a suggestion. It could be more if it needed to be. That if your right ventricle is failing more than your left ventricle, once again, back to that preload idea of being dependent, increase of 0.3 above recent baseline, which meet the definition of acute kidney injury. So obviously we would be worried about a pre-renal condition and wouldn't want to take off as much fluid. A baseline serum creatinine greater than 2 for similar reasons. And then if there's some sort of instability, hemodynamic or otherwise, that you may want to back off and be a little more gentle in how you're approaching the patient. So these are some of the considerations, and obviously these aren't set in stone, but I do think they've worked well for us, and I think it's been helpful. Anywhere where you're starting this therapy is something that maybe you're not familiar with, or your center used to do it a few years ago, and now you're standing it back up. I think you just want to be as conservative as you can be to make sure that you get the outcome that you're targeting. And so these are some considerations that you might do. Looking titrations based on blood pressure, heart rate, urine output, all those things may be important. But obviously, once again, can you be too aggressive? Of course. And every patient is an individual. And the idea that you can just look at a guideline and think that's going to apply to everyone probably is not true. So just something to keep in mind. So if you're seeing those serum creatinine bumps, once again, worry about a pre-renal state. If you're becoming a little bit on the soft side from a blood pressure, maybe you want to drop it purely because you need more volume. If your urine output is starting to drop, once again, maybe you have a low amount of circulating volume. You're not perfusing the kidneys as much. And then obviously, a response with a heart rate increase would imply that your cardiac output is dropping, possibly because of stroke volume, because of preload. So your heart rate is trying to compensate for that. Something to think about if you see that clinically. And then you may consider holding, so actually stopping the ultrafiltration if you see any of these following parameters. So if you're seeing a significant creatinine bump, so 30% could be a lot, especially if someone came in with a creatinine of 2. It's something to keep in mind. That's probably pretty significant, and that's going to be AKI, or 0.4, which once again would be an AKI definition. Drop in systolic blood pressures is going to be important. Resting heart rate increase, as we just talked about, over the 6-hour duration. These are the things that you want to check if you hold ultrafiltration, and maybe you're thinking about even restarting the therapy, is that you want to reevaluate once you have lab data available. And if you think the hemodynamics are stable and that your creatinine is relatively plateaued or even decreasing, then consider restarting the rate, but about 50 to 100 cc's less than your prior rate. You can always dial it up if you need to. And then if volume overload is present and it's persistent, maybe you want to think about how could you augment things like the cardiac output, which obviously could be in the forms of inotropes. You could talk about weaning vasodilators, especially those patients with preserved ejection fraction. Or maybe you'll consider a right heart cath when patients don't respond to the typical course of therapy in a way that you anticipate. based on guidelines, you might consider a right heart catheterization. So this is a pathway that we've been talking about, and I think it's a very interesting pathway that you could consider for someone when you're leveraging the SMARTFLOW system in clinical management. So obviously we've talked a bit about the symptoms of fluid overload, and everyone is familiar with all those things that we were just talking about. You know, and classically for us in the outpatient space, a lot of times it's just going to be a weight change, that they've gained 3 pounds in a day, 5 pounds in a week, whatever it is that you feel is an indicator of retaining fluid. Those are the times you need to think about, well, what are we going to do? And so obviously a lot of those patients may be on diuretics unless it's a new onset, acute myocarditis, something like that. So oftentimes we would say, well, what's your baseline dose at home for diuretic therapy, loop diuretics? And we would typically talk about maybe doubling that dose. Or you could do this thing called a furosemide stress test, which a lot of people may not necessarily be as familiar with, but it's an idea to give you some insight into the potential of diuretic resistance, which a lot of what we're talking about is driven by this concept of diuretic resistance, meaning that's an opportunity to pursue ultrafiltration if you think a patient is not going to respond to diuretic therapy. Because one, that hospital stay is going to take a long time, and two, you're likely going to ding the kidneys more than where they already are to begin with. If they haven't been on diuretics, you could consider a one-time dose of 40 milligrams. Most of us, I think, in clinical practice, and a lot of nephrologists and otherwise, would attempt a 1 milligram per kilo IV bolus. Some people would even go higher than that. And then you're really going to assess and see, well, what's the response to that therapy? And so what we're really wondering about is, what's their urine output over the first 2 hours? Or we can actually look at a spot urine sodium. And if we take away from that we don't think they're going to be responsive, meaning they're not putting out that 200 per hour based on those therapies, well, that's probably a time to think about an alternative strategy. And we already saw, we do think that early initiation leads to a better outcome. So if you knew that on the front end and you can implement AQUADEX early in the hospital course, I think that portends a better prognosis. And I think you're not going to continue to sort of beat up the kidneys with pounding them with diuretics when the kidneys are probably doing about as much as they possibly can. So obviously for this, there are some important considerations. One, you need your training, you need the console, the machines, but the biggest consideration, I think, practically from a time perspective, is the vascular access. And how are you going to do that? Are you going to use a central catheter? Are you going to use a peripheral access? Either way, you're going to need someone to help you to facilitate the acquisition of that access. And so we've come up with our own strategies at our place, but I'm sure everyone has their own thoughts about how that might work best for them. And then back to the guides as far as the rates that we talked about earlier, based on hemodynamics, on systolic blood pressures, might inform at least a starting point. It does not mean that's where you have to stay. It does not mean you cannot up titrate. It does not mean you cannot down titrate. But you may want to think about decreasing once again if we saw some of those things like RV greater than LV dysfunction. So maybe it's an RVMI or something like that you have to think about. Those are important things, or maybe it's a pulmonary arterial hypertension, or whatever the case may be, where the RV may be more severely affected than the LV. Obviously, that once again, those AKI criteria that we want to pay very close attention to. And then, any kind of history of instability, and everyone has seen patients like this where they don't always behave the way that you thought that they should or that they might. And so that's where paying close attention to patients, and I think it's a local decision about where do you want to do these therapies. Is it something you want to start in an ICU? Is it somewhere you want to do in a step-down unit? somewhere do you want to do it on a regular floor, but maybe with telemetry or something. Those are things that you want to consider when you're standing this up in your own hospital. And then obviously the goal is the euvolemia. And, you know, and you're going to have a lot of different ways that hopefully you can assess that. Some of that is going to be based on physical exam. A lot of it, honestly, in my opinion, is how the patient feel. You know, how are they doing? Their dyspnea score, is it greatly improved? Can they go back to doing their activities of daily living? Those are the things that I think that you're not always going to capture in an EMR, but it's something that you can talk to the patient and find out. So this was a white paper that came out, and I do think this is important. It sort of sums up a lot of the things that we talked about, that, you know, maybe you're not always going to have access to invasive cardiac output monitoring. And, you know, if you're not in an ICU, you probably won't. But you can use SpO2 monitoring, and that's really a pretty good correlate with the cardiac output. So there is this idea that if you use both the hematocrit for the reasons we talked about and the SpO2, the likelihood of a safe and effective course on ultrafiltration, I think, is much higher. And this comes back to some of the things that we've already talked about, is about, you know, just, it's a lot of this is common sense. If you think patients are becoming hemoconcentrated, that probably tells you your intravascular volume is a little bit too low. So all those sorts of things you want to consider when you're managing the patients. And I would say one great thing about this therapy is there's always someone available that can coach you, that can talk you through this to say, this is what I see. What do you think that I should do? And I think that's a very important thing to take away. So when do you want to start therapy? I think these are some nice mnemonics, start and stop. So obviously someone who's a frequent flyer, like we talked about, probably means they've never really been achieved true euvolemia, and they're probably not compliant. And so all those things may have some sort of input into saying, well, maybe this is a better therapy. You see that creatinine starting to bump. Once again, intravascular volumes are going down, doesn't mean the total volumes are where you want them to be. If they're unresponsive to diuretics, we talked about. If there's inadequate urine output, we talked about. And then if you have an idea of what their dry weight is, 10 pounds or greater is probably a significant amount of volume and something that needs to be managed. And then when you stop, back to AKI, or maybe you achieved where you wanted to be, or just hemodynamically the patient isn't tolerating it. And I'm sure everyone on this call is very familiar with, you know, those hemodynamics that we're concerned about, whether it's some sort of an extracorporeal therapy or otherwise. You know, we want to maintain our end organs such as our kidney, and we cannot do that without adequate blood pressure. So these are some of the standing orders, and I think these are very helpful. Once again, it may be something that you do some sort of nuanced version of this at your own local institution, but you want to have an idea of what is it that you're trying to accomplish. And I think in heart failure in general, we don't really do that. When the patient comes in, we don't always know what the fluid removal goals are. Maybe we want to get to dry weight, but we don't say when and how quickly, right? And so once again, you may want to get them off of 15 pounds using a traditional therapy, but are you going to induce AKI in the process? So that wouldn't be a very thoughtful strategy. Obviously, how fast you're going to run it and when you're going to go up or down based on the things we've just talked about. Anticoagulation being important to maintain those filters. And then are you going to leverage this hematocrit either, you know, where the machine will stop based on a pre-designed number, or it's at least going to alert you about what's going on. So I think for us, the therapy really is pretty straightforward. It's very simple. I think in our place, everyone was a little bit concerned about this new technology and, you know, this is going to be challenging and we're so worried. And then, you know, after they've done it, like, this is so easy and it makes so much sense and the patients feel better and it's really very good. And you can get by with a 4-to-1 ratio, which obviously is important, especially in systems now where so many healthcare providers are absent or quarantined. You just may not have enough people to do everything that you want to do. I do think it's important to have this idea of the peripheral access for the reasons that I discussed. And you just don't really need much extracorporeal volume to be able to do this. I mean, 35 cc's is not very much. And then this idea of making it even more straightforward to use and when to slow down, when to stop, leveraging the hematocrit sensor, the SVO2, all those things are giving you additional objective clinical data to inform your management and your rate. So with all of that, I appreciate your concentration and your patience. I hope that you've learned something through all of this. And I think we would be happy to take any questions that may be out there. So thanks again.
Thank you, Dr. Jefferies. This was just a wonderful overview. There are several questions, so I'm gonna go through these the best that I can. And if you can just, give us some answers, that would be great. The first is, how do you deal with a mild rise in serum creatinine, but a significant reduction of fluid? Do you ever correct for the fluid balance and the concentration effects on the serum creatinine?
It's a great question. You definitely could. I think someone there is really understanding the cardiorenal syndrome, so I would not be opposed to that at all. I think it makes a lot of sense. You have to remember the way we define AKI, and this person obviously understands, is really based on that 0.3 increase or a change in urine output over time. But the patient's not the same patient from the day of admission to hospital day 2. So I think that's a very thoughtful approach, because at the end of the day, in my mind, one of the major goals of this therapy is that we're trying to avoid AKI as much as possible. And, so if you're not thoughtful about that, about what is your volume status now, and you're going to continue to crank through this, your likelihood of your creatinine bumping, if you're not thoughtful about those different conditions, quote unquote, could definitely occur. So I think it's a very important point to remember to treat the entire patient in front of you. So a very thoughtful question.
Great, thank you. I know that we talked early on about just the readmission rates, and if you could sort of give us some of your experience with AQUADEX and reducing readmissions.
Absolutely. So I'll tell you, so in my prior institutions, we were large consumers of ultrafiltration. And so one experience that I had, or we published in a CRRT paper a few years ago, was this idea that, this therapy, when you think about it, is almost gravitates towards that HFrEF population. But almost half of what we deal with is HFpEF. So, and the thought was, well, you can't use this technology because of the preload dependence. You're going to hurt people over time. And we actually were able to show that you can do it safely in both HFpEF and HFrEF with exactly the same outcomes and the same safety profile. So I think that was an important takeaway for me. In our experience, what we've done is, so in my local institution, we've been instituting the therapy in a very controlled way. So we have 5 hospitals as a part of my service line. And so we thoughtfully picked a couple of places where we knew there was a high prevalence of heart failure. We saw a lot of bounce backs, a lot of readmissions, and how could we use the technology? But I think most importantly, we had a champion there, both on the administrative side, on the physician side, on the nursing side. And we've worked well with cardiology and nephrology in a partnership, which obviously I think makes sense for this particular technology. So we've just started looking at our single institution, so 2 center, 2 hospital data points. And what we've seen is that 60-day readmission rate, and granted, these aren't huge numbers, but we've seen a reduction of about 63%, which is even better than what most people would anticipate, right? So what we're saying is, if you remember back those slides, about half of those people at 60 days are going to be readmitted. Well, now we're saying we're dropping that number to a significantly lower level. Once again, changing the mortality profiles, the trajectory of that patient, and the overall cost, and hopefully saving their kidneys in the process.
That's great. And you hit on 2 really important things in terms of cost and morbidity and mortality. I wonder if you could speak a little bit too, just in terms of the patient experience, because I know as we practice now, the outcome and the experience that the patient has is really paramount to that.
Yeah. So for us, I'm a firm believer, you know, I'm a card carrying member, heart failure, you know, transplantologist, but the endpoints that we focus on in RCTs or FDA studies and whatnot, I think is just, it needs to be revisited, because for me as a provider, I think one of the biggest components that we don't capture in a traditional MACE outcome is quality of life. And so we are getting better about that, but I do think that it's amazing to me how we might treat a patient aggressively and think that we did a good job, but maybe they actually feel worse leaving the hospital when they showed up. That patient's probably still going to be discharged based on traditional parameters. I would say that's probably not the best thing. And so what we've tried to do is incorporate a few things. So one is, you know, there's a simple dyspnea score that I'm sure everyone has seen. Just you know, it's just a Likert scale of how difficult is it for you to breathe. But we've also tried to bring in some quality of life scales. And so we're going to start using those in admission and then at discharge, where they're really more concentrated on quality of life and with a heart failure focus or a cardiovascular focus. And I can tell you our preliminary data are quite compelling. And we have some patients that literally will tell you that they have never gotten all the fluid off in the last 5 years. They've been to the hospital over and over and it never gets to that point. And some people we're talking about maybe lose 50 pounds during an admission. 50 pounds, that's, you know, carrying half a person basically with you all of the time. People feel so much better. And like I say, I think that that's a component that we just miss, is that, hey, I kept the creatinine within a certain range. Well, what I really care about is, does the patient feel better? Do they feel like they're back to their baseline? And do they understand how to avoid getting back into that volume overload spot? So we're using the traditional objective outcomes, the 30-day and 60-day and AKI and all that other kind of stuff. But I hope we're trying to, once again, treat the patient like a whole patient and not just a kidney biomarker.
Great. That's a great answer. I know you talked a little bit about the HFpEF, the HFrEF, those patients that were preload dependent, but we have a question about treating patients with UF that have cardiogenic shock and some experience that you have with them, because they are a hard cookie too.
Yeah, that's a tough one. I'll say that, you know, we haven't had as much experience locally with that, but I will tell you that across the country, people are dealing with this in the setting of COVID. So obviously those patients can come in viremic, diffusely inflamed, hypotensive. So those sort of severe cases that you grade 8, but the management of those patients is they're going to volume resuscitate them, and those leaky capillaries is going to lead to volume overload and third spacing. So there are some institutions in New York and other places, which I believe are writing up their experiences right now, that have been able to use the technology safely. And it still comes back to the same thing. You have a patient ventilated with pulmonary edema and you want to try and get them off the vent. Well, you're not going to do that until you mitigate their pulmonary edema. Are you going to do that with diuretics? Maybe, but it's back to exactly the same argument that I made. You're going to drive an inflammatory response with diuretics and you have no idea how much fluid you're going to take off. And someone who's actively inflamed, who their blood pressures may be labile, if you can control how much fluid you're taking off, that is a much more informed way to do it. And I can tell you, some of my heart failure colleagues have been really impressed, I think, with what they can accomplish in these sick patients, right? I mean, these people are not, I mean, no one really knows what to anticipate for COVID patients in general. I'm sure there have been other uses for just traditional septic bacteremic kind of situations, but I think the most pressing issue now is, how do you deal with those sick COVID patients that are mechanically ventilated, by definition going to have a worse outcome? How can you mitigate things and preserve their kidneys, get the fluid off and get them off a ventilator? And I think that just a common sense thing would say this makes a lot of sense. If I know how much fluid I want to take off, I dial it in and I do it. And if it's too much, I slow down. And if it's not enough, I dial it up. So I think the intuitive nature of the therapy makes it very useful.
Great. Okay. And one last question, because I know we're past the hour, and thank you so much. How has the ease of use of this particular device in terms of, from a nursing standpoint, how has that impacted nursing adoption in your institution?
I'll tell you, like I said, you know, a lot of our staff, not just nurses, but other, you know, members of the team, I think were a little bit worried, especially because it's extracorporeal, right? So we're taking blood out of the body and putting it back in. Everyone is maybe a little bit concerned about that if they haven't done it before. And I'm just impressed to say that probably our biggest advocates for this therapy are nurses right now, unequivocally, because they see, I think, one, they feel like they have some control over what's going on with the patient, which they do more than diuretics. But I think it's that they can interact with the patient, and the patient is seeing these real-time results of this bag filling up. I think they feel very empowered. I think they feel very comfortable. And I think it helps everyone to feel more a part of the treatment paradigm. So for us, I would say our nurses are probably going to do a better job of talking about this than I would actually, but I appreciate y'all listening to me anyway.
Great. Well, thank you so much, Dr. Jefferies, for your time today. And if you all have any additional questions, certainly we can be reached at product-support@chf-solutions.com, as well as through our website. And then this will be also available on our YouTube channel as well. So thank you so much, Dr. Jefferies. Thank you all the participants for your time and attention today.
Thanks, everyone.